is a part and cannot be eliminated from the algorithm of the treatment, and that a lot of the medications being used in that, including the systemic steroid, in addition to immunosuppressive and immunomodulatory drugs. So mycophenolate mofetil has been used and showed that really success rate in this treatment, apart from the suppressing the inflammation and improvement to the treatment. We have systemic methotrexate, either oral or subcutaneous, is being shown that in the reports it is really helpful in the management of euphatic macroedema. Another new medication just introduced in the previous decade in the treatment of euphatic macroedema is the biologic, either systemic or even though intravitreal, as mentioned in the previous talk. So among the common medication that been under trial and used in the retrospective manners is the interferon alpha 2A and interferon alpha 2 as one of the immunomodulatory medications, and showed actually a good result, especially in the patient that having Bahja disease that associated with euphatic macroedema. Another type of biologics is the tumor necrosis factors alpha inhibitors that being used widely in our era nowadays, including infliximab, and showed really a good and excellent options for treatment of patients with refractory type of intraocular inflammations, and showed very good result in euphatic macroedema response. In addition to that, we have adenomab, that one of the biologics that FDA approved for the intraocular inflammations, and we compare it with off-label medications, and showed systemically at subcutaneous and as well intravitreal some really promising result as well. We have another anti-interleukin 1 beta, givasogumab, is being used in the trials as well on the anecdotal reports, and show some benefit, but not that as with other medication. We have another biologic, tocilizumab, anti-interleukin 6, and showed as well certain success rate and improvement. Daclizumab is really being used in certain patients and showed good response to the inflammations, but when are looking from the macroedema, actually is not effective as previously. Rituximab being one of the powerful medications used especially for scleritis and intraocular inflammation, but anti-CD20, but actually is not that really effective as the previous. And lastly, we have aflibercept, anti-CD11 is one of the medication being used in the practice to use this medication in general. It's not cannot be used as a first line of treatment, but could be used as the second or third. As you know, this is cost effective, and this is really biologic treatment that targeted to the certain types of inflammation. So if you're looking, we have a lot of evolving and a lot of research in that, but till now we don't have really one of them that showed that really significant treatment offer others. So we have to keep that in mind. Option of this medication is helpful, especially when we have refractory resistant euphatic macroedema not responding to all modalities that will be mentioned in this webinar tonight. If you would like and interesting to know all the details of the studies and clinical trials, you can get back to the reference of Corinis. It al. Showed really good tables, summarize all this type of medications and biologic that by the time being in the practice for treatment and under trial to see the efficacy and safety in the treatment of euphatic macroedema. So this is in general the treatment options that are available for treatment of the euphatic macroedema. The essential part to suppress aggressively the intraocular inflammation is the first role in treatment of euphatic macroedema, in addition to adjunctive treatment by non-steroidal steroids, and even though the systemic treatment or intravitreal implant, as mentioned by Professor Kwan. Looking for the prognosis of euphatic macroedema, untreated euphatic cystoid or euphatic macroedema tends to cause progressive injury to the macula and visual loss, and the visual loss related to euphatic macroedema has been associated with photoreceptor permanent damage, irreversible, macular ischemia despite resolution of edema on OCT and fluorescein angiography. And the end stage of uveitic macular edema characterized by thinning and fibrosis of the retina, refractory to medical treatment, and carries a poor visual prognosis. What are the factors could predict the prognosis of uveitic macular edema response to treatment? The type of uveitis entities, as more posterior type of uveitis like pan-uveitis or intermediate uveitis showed more really poor prognostic factor. Duration of uveitis, as long as patient having uveitis, as mentioned by Professor Kwan, repeated accumulative effect, it might lead to permanent damage of the retinal pigmented epithelium, photoreceptors, and then the mechanism of bumping and drying of the macula is being stiff and cannot be easy back to the normal. Then the age of the patient, older patient having less or predicting the prognosis is not as that young patient. OCT thickness, as the thickness is high, more than 500, 600, is really one of the predictive factors. As well, the increase of vascular foveal vascular zone, as this is indicating of capillary dropout and decrease the blood supplying to the macro area, it might be interfere with the prognosis of uveitic macular edema. And then presence of vitreomacular traction and epiretinal membrane, as you know, this is more surgical. Chronicity of this might be permanently affect the response of uveitic macular edema. So indeed, that previous studies documented various prognostic of the poor visual outcome in uveitic macular edema, including the prolonged duration of the uveitis and CME itself. So that's important to discuss it with your patient at the beginning of the treatment of uveitic macular edema, putting in your mind that quiet and inactive uveitis anteriorly and posteriorly. Prolonged duration of the uveitis and activities is really actually, it could by itself affecting the prognosis of the uveitic macular edema. And large foveal vascular zone, as we mentioned earlier, the presence of complete vitreous detachment and epiretinal membrane and other factors, and increased macular thickness, diffuse macular edema pattern in OCT, and the advanced age of the patient. And indeed, as well, the OCT having a lot of biomarkers that could help you to see the prognostic factors of uveitic macular edema, including hyperreflective spots that present in the combined type, diffuse, cystoid, and serous retinal detachment is really showed. And the other thing is that even though the loss of the photoreceptors and really thinning of the retina in general. So these things together, put it in your mind when starting treating your patient, and then you can plan your treatment options. And even though that you know how much in the beginning, you need to do all your parameters, OCT, fluorescein angiography, OCT angiography if you have it, and really evaluate the patient accurately as a baseline. Then you can proceed your treatment, and then you can monitor your patient by OCT to know how much of this patient in thickness and even the visual acuity. So in conclusion, uveitic macular edema represent an important vision threatening disorders occurring in the course of the various uveitis disease, and it is associated more commonly with more posterior located uveitis like intermediate uveitis, posterior and pan-uveitis, and untreated uveitic macular edema tends to cause progressive injury to the macula and visual loss, and fluorescein angiography and OCT are essential in evaluations and follow-up of uveitic macular edema. The combination of intraocular inflammations with topical periocular intravitreal steroid and anti-vascular endothelial growth factor are the recommended treatment of cases of uveitic macular edema. And lastly, I would like to thank you all. Special thanks for you, Dr. Noor Al-Qasimi, for giving us this chance to share our experience and to participate in this webinar. And thanks as well for my colleagues, Dr. Professor Kwan and Dr. Igor Kozak. Thank you all, please.
Thank you, Dr. Hassan Al-Dibi, for your talk, and thank you so much, our dear speakers. Regarding the, let's talk about, when you said about the vitreomacular traction, What's your opinion, and when do you interfere for vitrectomy, Dr. Hassan,
Yes.
as a visual prognosis?
Yes.
Yeah.
Yeah. This is an important when I said that in the early part and basic work for the uveitic macula, you have to do an OCT. And this is essential to show you the relation between the vitreous interface and the retina. So sometimes you might have just only vitreomacular adhesions, which is really is not affecting the contour of the macula. So trials of intravitreal steroid, either injections or implants, or sometimes anti-VEGF, it could help to release this and lead to posterior vitreous detachment. In cases that persist and the macroedema thickness is high, this is where might be an indications of vitrectomy. Patient with vitreomacular VMT, which is abbreviation for vitreomacular traction, and from the beginning you can say that is it broad base or just only single base. If it's just only small epi centers, then you can try this options and it could be released easily. If not, immediately you cannot wait and go for a vitrectomy, which is give you the problem with that vitrectomy. Sometimes you are using the vitreous gel as a professor for that areas that to contain the medication, so that give it time to be released and helpful in the making the duration of the release treatment longer. But if it is the reasons for the the pathology, it's really indeed need the treatment.
Okay.
Surgically.
Yeah.
Just along with
yes, Prof.
Just along that line, for any of us who have ever peeled membrane from uveitic eye, just please be patient. This membrane would usually cause traction enough and cause edema, Dr. Hassan had mentioned, usually do not come off so easily as in, let's say, an epiretinal membrane in an elderly individual without uveitis. They usually come up in pieces, and because they're very sticky and adherent to the surface. So just have some patience, because you shouldn't expect, or it often does not come up at one nice piece as we see in senile epiretinal membrane, but rather they come in different pieces. And so just have patience, and eventually you will get most of them off.
Okay. Talking about the topical, I received a couple of comments from Dr. Avinash and Dr. Qasim Al-Hamouri regarding the topical steroid, which is difluprednate. Prof, do you use it? Because they said it's really a magic drop, and as I know that it is really helpful for the uveitic macular edema. Tell us about it.
So my experiences with topical difluprednate is average. It's not, definitely is not 100% successful. And I have come into the style in which if I were to start the patient on topical steroid for macular edema from uveitis, I often also use it in combination with a non-steroidal as well. So I combine both the topical steroid and the topical non-steroidal drug in there because my success rate with topical difluprednate, and that's been shown as well too, is not very high by itself, especially cases that often get referred to us at the academic center where it's been on for a long time. So you definitely should consider it if you need to, but if it doesn't work quickly, and I usually give it about 8 weeks or so to begin to see some effect. If you don't see it, you either should add a topical non-steroidal or use it from the beginning or change in a different approach.
So you combine both for the
Yes,
maximum?
I combine both. It is very, very rare. In fact, I don't recall the last time I actually do this, where I just use the topical steroid alone. Because we know non-steroidal have a different approach, usually to the COX inhibitor path aspect there. So it's better when you use multimodal approach to control this, and I think that would be appropriate. I don't know, Igor and Hassan, do you typically use at the same time too, or Dr. Nora, or you use them sequentially?
Yeah, myself, I'm using that as a combinations. I'm really a little bit cautious when I'm using non-steroidal for a long time because it's not free of side effect, and it could affecting the retina and lead to melting. So we have to be careful. The new generations of non-steroidal anti-inflammatories, it showed really in the practice and in the trial some effect in the uveitic macro, but I'm not using that for that uveitic macro with increased central macro. Some uveitic macrodema in the range of 350, and that could help. But cases with the really very having cystoid, uveitic macroedema, or central macro thickness of more than 400, 500, the effect of non-steroidal is usually limited, even though the topical. I don't know about Igor.
Yeah, I'm usually more aggressive, and if I use topical, I usually use it in eyes that show some macular edema, but the vision is still good. I am just paranoid about, inflammatory activity in the macula, and also my threshold is quite low. I do not continue this type of treatment for more than 4 to 6 weeks. That's like maximum. If I don't see effect within that period of time, then I switch to more aggressive treatment.
Yeah, for myself, I see the eye overall and how the patient should be aggressive, as Dr. Igor said, because uveitic macular edema is sometimes according to the visual acuity and even the thickness. So I can so I evaluate the eye itself overall for initiation the steroid, and how frequent shall I apply it, ask the patient to apply it per day. But I don't prolong that much. The problem is that there is a refractory, and here the scenario differs, goes to another way.
One other approach that we have not heard a lot yet today, which I thought actually very helpful in cases, is the use of carbonic anhydrase inhibitor, either topical and or systemic. And a lot of time now I move to systemic. So the use of, for example, acetazolamide or any of the topical version, I wanted to find out what is our colleague experience like. Certainly, my experience has been quite well. Again, not 100%, but oftentimes I use it before I move on to, let's say, a biologic or a steroid, is to use a systemic carbonic anhydrase inhibitor. Again, take into account all the potential side effects with the systemic CAI, including, for example, hypokalemia. So, but we are thinking of it in terms of a short term, definitely not a chronic treatment. So I'm curious to see the three colleagues here, Dr. Igor, Dr. Hassan, Dr. Nora, what are you using them at all, or where in your chain do you use amid all the choices we have?
Okay, let me start regarding the CSR due to systemic steroid in an uveitic patient. There are some couple of patients that I saw that developed CSR due to steroid. Here, the Diamox or the carbonic anhydrase inhibitor tablets, I initiated as a medication for the unfortunate patients due to CSR. So this is the thing that my next question for you regarding the Diamox or carbonic anhydrase in patients with CSR due to steroid intake in uveitic patients.
So if it's a CSR situation, yes. So first of all, if I determined that is due to that. So first of all, the first thing one would do would be obviously to try to stop the steroid, yes, because we definitely don't want that inciting thing. I have used several times the CAI with to treat that to the CSR. Again, the success rate I have is not 100%, but it responds some cases. Most recently, quite interesting, and I have seen several cases reported now for treating up CSR from steroid, and it's quite interesting. I don't know yet experience, but several colleagues has reported the use of periocular steroid, not systemic steroid, periocular steroid for the treatment of CSR from systemic steroid. So in other words, these are patients who've been treated with prednisone and for whatever reason developed CSR, and then the authors remove the systemic, and then as a form treatment, they report a series of cases where they treated with periocular steroid. And the rationale is being explained, but somehow that's improved with that aspect. But again, that's quite peculiar. So that's a little bit newer that we just been seeing now in the literature a little bit. But going back to the using of CAI, Igor or Hassan, do you use that at all systemically in your patient?
No, actually, I'm not. I didn't have an experience to use Diamox or correlates in this patient who was having CSR induced by steroids. I have an experience with one of my patients who was diagnosed as a case of PKH and being treated aggressively with systemic steroid. And when I look for the picture, it wasn't go with the PKH. So then I realized that this patient is really CSR rather than to be. So what I did, just only I stopped, that gradually I decreased the systemic steroid. It was really large dose for a long time, so I couldn't just stop it. But I'm assuming when a patient having CSR, you might use them, a lot of medication that like, spironolactone, treatment, it might help. This treatment usually is not an easy, and you need to do a lot of medical work for these patients. And the risk of, as you say, that hypokalemia, and even though the patient tolerance to the Diamox is not usually as expected that good.
Yeah, I haven't used it systemically. I've used it topically in 2 patients who had both uveitis and glaucoma. And in one case, I would say it has improved and stabilized the vision. In the other, it was not effective at all. Just topical carbonic anhydrase inhibitors.
The systemic dose is worked quite well, and you can start with 500 Q day and then 500 milligram once a day, and if they can tolerate, move up to 500 milligram twice daily. But again, we need to warn the patient some of the side effects, the tingling of the finger, and we need to explain that this is clearly not a long-term treatment. It's enough for us to get the fluid to get away, and then we get them off of that. But that's another tool that we can have before we can go on to other things, and soon we can go back now to discuss other aspects there.
Okay. There is a Dr. Fawaz Al-Ma'mouri. He raised a question. What is your experience, panelists, in treating CME or uveitic macular edema secondary CME secondary to retinitis pigmentosa, which is also considered as a part of inflammatory macular edema?
Well, if I may start, we actually published a paper on it with Ahmad Mansour using Ozurdex implant and repeated in some cases in macular edema associated with RP, and it has shown efficacy in close to 70% of cases. So it's a good option. Again, bearing in mind, all the precautions we need to think of when using this therapy, but it's therapy that works.
The other situation is that, Nora, some of the initial work of the use of topical CAI was published on this particular thing here. So the use of topical carbonic anhydrase inhibitor has been shown to help with macular edema secondary to retinitis pigmentosa. Some other study have looked at intravitreal methotrexate, for example, but I don't think that was very reproducible data. So that didn't help. But if you go back, some of the initial work coming out from Illinois Eye Infirmary has been using topical CAI for this particular indication that you mentioned.
That's Gary Fishman's work, yeah?
That's correct. Yes, that's correct.
It's great to hear about this. I'm using that's just only topical, that medication in these cases, and like Trosops. But looking for the steroids could be good options. But unfortunately, this patient, they are at risk. They have, the prone to have glaucoma, and they have usually their visual acuity is not that obvious, as you know, so that anything that could go in that way, it might. So that balance, I think we need some sort of clinical trials to compare this medication in certain, small groups, so it could be remote using the intravitreal steroid in this patient, especially for, because this is recurrency, and as well the refractory type of macular edema, and the inflammation is not 100% being sure it is the behind the retinitis pigmentosa macular edema. So we need to be cautious when we are starting to use that, rather just only. I will use it only for the patient, really, in a form of trials.
Okay. There's a question to Prof. Kwan from Dr. Al-Bakr. How frequent you use the implant in case of Behçet's disease? Because it's usually associated with systemic complaint and severe uveitis. Sometimes might reflect CNS activity. Need to know your experience of using implants with Behçet's, and does it mean to stop immunomodulators, for instance, 1 to 2 years?
Yeah, that's an excellent question there. So many colleagues in your part of the world are actually expert in Behçet disease, and so. But here's a thing that all of us can consider. So Behçet disease is clearly known to be a systemic disease with multi-organ involvement, the kidney, the brain, and the eye, among others. So when we use this, we have to think of treating Behçet disease as treating of a systemic disease, and oftentimes in various countries, and so the use of TNF inhibitor has been considered nowadays the first line of therapy for the treatment of active Behçet disease, in particular the use of infliximab for that aspect, and very successful. So let's say that you are able to control the systemic disease, decrease the incidence of oral ulcers, and control there's no renal involvement or so. And let's say initially you have bilateral disease in the eye, and now one of the eye is quiet, but the other eye still have optic nerve inflammation or retinovasculitis that's not well controlled. So at that moment, you have a patient with Behçet that already well controlled systemically with systemic therapy. Now you only have the eye that's active. So rather than subjecting that patient to a much higher dose of systemic therapy and potentially with side effect, because it's now a local situation, you can then consider the insert of the steroid insert in the eye at that point, because there now you are well controlled with the eye that you're treating. You know that the rest of the body is very stable. It's just one right or left eye, or even both, that have the problem. Then you can put in the implant. So the goal there would be make sure that, as you already alluded to, this is a systemic disease, and the systemic disease need to be under control first and foremost, so that you can save the patient life. And then if need to, then we use local therapy like this, Dr. Igor and Dr. Hassan mentioned, to treat the eye, and at that time you can consider the insert of the steroid insert.
Yeah, I entirely agree with you on this route of treatment. Behçet disease is systemic disease. The most important to treat it systemically, and we have a lot of reports that been published regarding to the best treatment for Behçet disease that can deal with the intraocular inflammation and the development of macular edema and suppress the systemic. And among the medalists, we have that the infliximab showed really an excellent options for treat both. And looking for Turkish and Germany, they found that the interferon beta is really a great, choices to treat both. So it is really there is, and this has been supported by clinical trials, just not only by retrospective studies. So the option is here to treat. If it is just only unilateral and the inflammation is really under control, then you can use the choice of intravitreal steroid by putting the implant. There are two types of uveitic macroedema in this patient. One of the persistent inflammation, low grade, or the secondary to an occlusive vasculitis that affecting the macula. So you have to differentiate between both of them so that you can use your best option to treat these patients.
Okay. Dr. Hassan, regarding, since you spoke about the classification, Dr. Altaf Arswala, she said, why do we classify the type of edema in uveitis? Will it change the line of treatment or approach, or does this help in prognosis for the patient?
Yeah, this can predict the prognosis of the patient. When you have, the central macro thickness is that big, being more than 500, eventually that affect the prognosis. Acute versus chronic, old versus young. The second thing's combined type of uveitic macroedema, the treatment and the possibility of refract, that resistance to treatment is there, so you put it in your mind. If I tell you that if you have big cystoid changes, and that could be predict that the that the elasticity and the stiffness of the macula is really effectively affected by the future treatment, and how much you go that you might need couple of or combined type of treatment to steroid plus anti-VEGF. So these things were actually it's not limited, but could predict the future prognosis of the uveitic macroedema. It's important to put that in your mind so that you'd be clear, transparent with your patient, and select your plan of treatment. Certain patient might be one-eyed patient, might be patient for a long time being neglecting himself, not being treated. So you have to know this before you start your plan for treatment. There is nothing is magic to treat, and as still if your all opens, it might be ended that you cannot able to manage this uveitic macroedema. And as you said, that show the percentage is that most of the cause for impairment of vision is uveitic macroedema in general.
Okay.
Sam, excuse me, do you think there is a component of neurodegeneration in uveitic macular edema, similar to diabetic edema, which also is inflammatory disease?
I believe in the chronic type, combined type for a long time, not being treated or touched, it might be affecting the integrity of the RBE and the neurosensory retina and lead. And we saw that in certain patients that they have very thin outer segment of the and inner segment of photoreceptor. So put that in your mind when you are evaluating your OCT. You have to look for these things there, and if there is escape or loss of that. If it's acute, it might be degenerated, but if it is for a long time, it might be the visual loss is permanent because of this.
Well, we know that structure changes with chronicity of edema, but what about neurodegeneration component as such? Do you believe it or not?
I believe in that, but not on all the in the acute cases it could be, but chronic cases most likely maybe the damage is permanent. I don't know about Kwan.
So interestingly enough, this question of neuroprotection thing has come up, and within the past 6 months, there's been a publication come out from a group called the User Study, which among the colleague in the US who look at patient who has been treated with the fluocinolone acetonide insert. We know the insert, the Iluvien, has been approved in the US and worldwide for both the uveitis, but the second indication for it, actually the first indication for it would be diabetic macular edema. So they've been using that, and in this user study, people were looking at, in addition to obviously the decrease in retinal thickness and thing, what happened to the ganglion cell at the optic nerve. And impressively enough, that the patient over a period of year definitely showed there has been a much less decrease in the rate of a typical ganglion cell loss in that aspect. So the question of, is steroid delivered in a concentrated situation like this, can be so-called quote-unquote neuroprotected. It's not seem to be presented. Although we have to admit that this thing, neuroprotection, is been a mystery to many of us. And I think of now, we don't have a very clear understanding of it yet. But at least based on this study, so the user study, it showed to be that there may have been some potential benefit with this aspect. So I would not be surprised if Dr. Ego and Dr. Hassan had mentioned that there is potential benefit over on this aspect as well.
I remember one of my patients, it's young, it was 14-year-old, and it's a case of PKH. And we're starting to treat this patient. He's been neglected, not diagnosed in the right times. And when he come to us, we're starting our medication. We looked for his OCT and looking for, photoreceptors, and we found really very badly affected. And the vision was around 2300. With continuity of treatment, after 6 months, I found this photoreceptor getting back and the vision recovered. So it's really, this is support that the neuro regeneration is there. But is it applied for all the cases of uveitic macroedema, or that inflammatory cases, or for these people who's for chronic very stiff macular edema, and it been for a long time in old patient? It could be do the same, or early treatment could help in that in young patients and acute uveitic macroedema.
Okay, so there are a couple of doctors who are waiting to open their mics for questions. There are also written questions, so hopefully we can do it on time. But we'll give the chance for the 4 attendees who are going to ask you, gentlemen. First of all, we'll open the mic for Dr. Noura Al-Sibai. She's the first one who raised her hand in the beginning of the webinar.
Can we see Dr. Noura on the gram too, so we see who's asking us this question?
Dr. Noura, can you, Marvijan, if you open the mic for Dr. Noura? Kindly unmute yourself. She's around, Marvijan? Can we go to the next attendee? Dr. Ibrahim Al-Anizi?
His mic is open now, so he should be able to speak.
We have Dr. Noura Al-Sibai, Dr. Ibrahim Al-Anizi, Dr. Arkan Al-Ma'mouri, and Dr. Carter Chabara. So any of the attendees are welcome to ask in the platform.
Yeah, Carter Chabra, can I go ahead?
Sure. Please ask your question.
He's muted now. Oh. He's muted.
Unmuted. Yeah.
Okay.
It gets muted. Yeah, my question is okay. Thank you very much for a very good seminar.
Thank you, Doctor. If you can just go into the question directly, so we can have the chance for the others. Dr. Carter?
Eels disease. Hello.
Yes, can you repeat your question, doctor?
Any experience of patient with Eels disease having macular edema?
So Eel disease, by definition, is a diagnosis of exclusion of that aspect. Once we have already ruled out other possibility, what we, or at least I have seen in Eel disease, are usually situation with retinal neovascularization that lead to, for example, vitreous hemorrhage and so on. So that has been the key thing for me, seeing an ill disease. I typically treat these cases in a way similar to diabetic retinopathy in the past, that is to perform laser photocoagulation in this type of patient in there. I don't believe that I have had many patients with ill, which are relatively rare anyway, to have macular edema. So I would think that if you were to see macular edema in the case that you definitely believe that truly should be ill, and based on the concept of neovascularization that form in ill disease, I would think that using that concept now thinking, maybe we can consider a VEGF antagonist for that aspect, because in ill disease, the situation there happened with, again, increase in increase in hypoxia, and therefore increase in the VEGF formation. And with the past that they have responded nicely to laser, and now cases with anti-VEGF, I would think that that probably where you can consider it.
Thank you. Thank you very much. God bless.
Thank you.
Thank you.
Thank you. Thank you, Dr. Kwan. Now the next is Dr. Noura Al-Sibai. Can you unmute yourself, please? Dr. Noura?
She's mute now. She's muted.
Okay.
Where she's now? Huh? So Ibrahim Al-Anizi is there.
Dr. Ibrahim Al-Anizi? Okay. Tell anyone, can we have a question from the audience? Dr. Avinash, he raised a question saying that, let me have a look. Yes. In patients with unilateral intermediate uveitis with uveitic macular edema, if there is a strong steroid IOP response, what would be the choice of treatment?
So this patient has unilateral intermediate uveitis with macular edema. And and now with active macular edema, and the patient already been treated, I guess, consider with both topical and also systemic steroid, and the patient has shown problem with steroid side effect and ocular hypertension. So not really a possible choice here. So then we can consider this patient and see, okay, so intermediate uveitis, typically in a young female group. So make sure that we talk about family planning when we choose about this issue here. Let's say that's been stable with, then I would again consider a step ladder approach in this case. I would most likely start a patient out in this case with a systemic CAI to see if I control it quickly. If not, I would then move forward to looking at some of the other biologics that potentially can be used in this patient. And we have had some very good success with IL-6 inhibitor, the tocilizumab, in this type of cases. So I would consider that. But just like other cases in uveitis, we go in a step ladder approach. So we consider things that are much more, perhaps a little bit easier for the patient to get first, and then see how it responds. But if you already failed steroid, or in this case cannot tolerate steroid, then the next one will probably consider a systemic CAI, and then moving forward using a anti IL-6 in this case will be in this aspect. Why anti-IL-6 versus an anti-TNF? Well, if we look back at some distinct situation in the visual study, which led to the approval of adalimumab, which is a TNF inhibitor in there, the response to macular edema can occur, but it takes quite a bit of time for it to get response. So we did see some response into a macular edema, but it takes very long time for us to be able to see that. So therefore, the IL-6 tend to be a little bit faster to do this aspect from there. And so that's the reason why I prefer that over the TNF inhibitor. And if you cannot find IL-6 and you want to use a TNF inhibitor in this case, then in this particular end, I would go ahead and choose the infliximab over the adalimumab first, because the way that infliximab delivered through the intravenous, it can lead you to improvement a lot faster than the adalimumab part. And again, this is in the setting of a patient who cannot be treated with steroid. So certainly with the other aspect as well, we have to consider that, and just please make sure discuss family planning and think if appropriate, so that way the patient know what to need he or she need to do.
I entirely agree with you, but we have to be careful when are diagnosing bilateral intermediate uveitis. So we have to make sure that we don't have an infectious cause of low-grade inflammations. Otherwise, what Prof. Kwan mentioned is the step leader approach is the best.
Okay. I think we are running out of time, despite of there are interesting questions and people eager to have answer from you, gentlemen. There is a mic, if you can unmute yourself, Dr. Arkan Ma'mouri. For the meanwhile time, I'm going to send a link. I'll share it with you, attendees, so you can receive your certificate once you write down your email, and it will come to you directly in your email. Dr. Arkan?
Muted. He's muted.
Okay.
Dr. Noura, do we have any questions that have been sent to us by
There are a lot of questions.
Oh,
let me,
any of them. That's why I could not see anything.
Yeah.
Sorry.
Okay, let us, there is from Dr. Noor Uthman. She said that my question is that how can we approach to a patient who needs cataract surgery with previous history of uveitic macular edema? Are there specific pre-op protective measures? It's a nice question regarding preparation of cataract surgery and history of uveitic macular edema.
It's a great, and I think one of the options to use intra-vitreal implants, either Ozridix or Olivine, is one of the really good options for these patients.
Okay.
So if you have a good response with that in the past, then definitely, Dr. Hassan said, you can consider that to place. Otherwise, if you have never treated before, the patient only have a history of recurrences, then you can treat the patient, pre-op the patient. I usually use it about a week before. Yeah, so the 7 days before, where you would consider a short course of systemic steroid in addition to topical steroid, just about 7 days of that. And then on the day of surgery, we will administer intravenous steroid. And then in the post-op course, depending on how the inflammation is, then you can adjust. Again, this is based on Dr. Noura's scenario of a patient with a history of recurrent macular edema from uveitis. So this is a high-risk patient. If the patient never have had any problem with uveitic macular edema, and the uveitis has been relatively quiet or easier to control in the past, then I think a topical course of heavy steroid, topical steroid and non-steroidal a week before is fine. But if they have had a history of recurrences, then definitely please consider systemic, because that decreases the risk of that. This patient had very high risk of recurrences after the cataract surgery.
Okay. Talking with the implants, in real life, the effect of Iluvien lasts up to 36 months. If not, on average, how long Iluvien lasts in the eye?
I thought to be very closely attentive to like around 20, 2 years to 2.5 years, so 24 to 30 months of this aspect of there. Again, and based on what we have seen with the registered previously, is very, even though say 36 months, but sometimes you see the activity lasts beyond that, and you see more than that. However, with this caveat, I also want to point it out that yeah, it is said to be 36 or 31, but one need to be careful with the activity, because what we have learned from the so-called the MUST study, the multi-center uveitis treatment trial, MUST, in that where we compare systemic therapy to Retisert, what they have learned at the 7 years is that the patient who were treated with the Retisert tend to have more diseases. But the problem is the average number of implants that was placed in that trial, it was less than 2. So while those who will receive systemic therapy receive continuously all systemic treatment throughout the 7 years, those who were randomized to the Retisert will only receive less than 2. And the claim is that because the investigator did not see activities in the eye that have the implant, so they did not treat, and therefore they wait for problem to occur, for example, subretinal fibrosis or choroidal neovascularization or whatnot. So my thinking is that, again, we have the implant in the eye and it's slowly controlled, but it would take a little bit of time to show you the recurrences. So at around the 24 or to 36 months, you should be quite actively looking for potential disease, because we may not see all of them at once. So look for fluorescein, look at OCT, look at multimodality to detect whether there's any evidence of recurrences. If so, then you should retreat them rather than wait until you see a real problem, and at that time it may not be reversible.
Okay. There are 2 last questions. Can you bear with me answering, and then we wrap up and before we finish from our dear attendees. Dr. Mahmoud Abul Atta, he said 36 years old male patient. You know, we have great speakers, so we need your input for the patient. 36 years old male patient presented with diminution of vision in the left eye, 660. Eye is completely quiet after severe attack of uveitis at childhood. OCT showed only extrafoveal thickening. Macular thickness was 265. His right eye is non-seeing, so he is single eye. What is the next step for the left eye? Is it like observation or what do you think?
I would do fluorescein angiogram to see the circulation and perhaps highlight that area, perimacular area of edema, and definitely assess foveal avascular zone and to look for macular ischemia. So before any treatment decision, I would like to have that test.
What's the vision, Dr. Noura?
660.
I'm sorry, 660, and the thickness is 265, and a single eye.
And there is no intraocular inflammations, is there?
Quiet.
By examination, quiet eyes.
Yeah, this is what they has.
So the concern here is we're asking the question, why is it 2200? I believe this is the correct conversion, but like, why is it 660? What is it that caused this patient visual acuity to drop? So Dr. Igor already suggests FA to rule out ischemia. Other thing I would really consider is this, to perform electrophysiologic testing to see what the optic nerve functions like to VAP, and look at multifocal and full field ERG for us to re-understand if there's a reason for this. So for example, if you do field and you do ERG and it's come back, ERG is nearly flat in the periphery, then you could say, okay, this may not be a regular typical uveitic disease because the patient is only 36, why is it all flat? Is then underlying genetic disease or some other diseases that have manifested like this? Because 2200 or 660 in an eye with no macular edema is a little bit unusual there. And so we need to evaluate why the vision is so low to the optic nerve, to the rest of the retina, that can give us a hint about what it is that we are seeing there.
Agree with you totally.
Yeah. And the last question, is there any role for vitrectomy for refractory macular edema without VMT?
So This question of vitrectomy for macular edema, and Igor Famito, he's a great surgeon, so he was shared to start a lot out in Japan, where many of the colleagues in Japan in the past has used vitrectomy as, in some cases, treatment for diabetic macular edema to remove with or without traction at this aspect. I think in terms of uveitic with macular edema without any traction, so the question would be, why do we do vitrectomy? The goal there technically would be that you remove the vitreous, which is a storage device for a number of inflammatory cytokine and things in there that would do in that aspect. So potentially that can help. So rather than, let's just say the disease is very localized to the eye only, and rather than giving the patient systemic treatment or even like implants and or insert and whatnot, if you do the vitrectomy, it is hoped that one will remove that stimuli or stimulating factor to remove that to help. So if you're going to do that, at least for your own interest, you should definitely have those vitreous specimens studied carefully to see what you learn from there. And then you then ask the question, if you do that, what will prevent it from coming back? So then one have to say, why, if we do this vitrectomy, we remove it, is there anything to prevent the inflammation from coming back later on once, after that vitrectomy? So certainly that's considered, and recall that in the past, there's been publication from Boston, from Miami, showing the role of vitrectomy in intermediate uveitis with macular edema. So that has been shown, but the theory would be to remove that and with the hope that it will not return. So
yeah, but this is actually in the cases where there is persistent inflammation not responding and persistent vitritis, I think so. It's just not only applied for all the patients with intermediate uveitis, I think.
Yeah, definitely. And I would look for the source of inflammation. Is it coming from the blood vessels? Is it coming from pars plana? Is it coming from, choroids? And I would do that to do also a little bit of clearing of visual axis. So I wouldn't do it initially. I would perhaps wait for more cloudy vitreous to, so that the patient can see a benefit. And that's an option. We have cases that really end up with lots of vitreous debris following vitritis, and vitrectomy in such cases is also therapeutic, but also a very good point from Dr. Nguyen to use it as diagnostic vitrectomy and try to look for some either cytokines or maybe some infectious causes.
Well, I'm not using vitrectomy unless there is reasons in that. If the media is clear and there is no vitreomacular reactions, actually, I'm not. This is like in my amentoriums for the treatment of uveitic macular edema. But if there is really and media opacities or recurrence vitritis that prevent me to evaluate very well the posterior pole, this is the time where I have to go. I found it very useful in young patient with intermediate uveitis that having recurrent, inflammations with vitreous debris and lot of floaters. But for sake of treating macular edema, actually it is not the first, choice for me.
So, yeah, Dr. Prof. Kwan, do you want to say anything regarding?
No, I think that our colleague students share very beautiful information already. The only other option that since we turn the topic of uveitic macular edema, I just want to share with everyone, and Dr. Igor and Dr. Hassan and probably you, Dr. Noura, already seen some of this data presented. So in the US right now, the study, so-called the Peachtree study, looking at suprachoroidal steroid. And that study was specifically designed for uveitic macular edema. So this is not to the insert implant, but rather to the suprachoroidal delivery of steroid. And that is being evaluated right now. The study was positive for that, so that may be a potential too. And I'm quite certain that eventually it will probably move to the rest of the world as well. But that is another approach. And that particular study is indeed for that uveitic macular edema that we're looking for. But so overall today, certainly it's been a wonderful experience learning from our colleague there and seeing friends. We have been logged in for so long now, so it's very nice to see humans and faces and smile again and things. So thank you, Dr. Noura and Dr. Ego and Dr. Hassan for having us.
Thank you so much, Professor Kwan, Dr. Hassan Al-Dhibi, and Dr. Igor Kozak. Hoping Dr.